Recording in progress.
Besides a handsome young man.
Who's that? Okay, so this would be complex commercial.
Just for the record, August 22nd, 2009 at 3:14.
What do you see?
Okay, so I'm going to escape now. Somebody has put in the chat box, please optimize. I'm going to refer you to my age, which is over 40. I have no idea what you're talking about, but hopefully in future, just for the sake of time, so we can get through this, maybe you can share with me how to do this so that I am able to do this in future. Okay, so, but hopefully you saw that this gentleman had this episode where you can tell he's conscious, but he is completely unaware of what's going on, and his wife or his girlfriend is trying to engage him, but he no longer converses. And most importantly, I hope you picked that out. I'll just do it again. Look at his mouth. You'll see he has repetitive, purposeless movements, what we call automatisms. I'll just share this again. Just look at his mouth.
August 22nd, 2009 at 3:14.
What do you see? What is it?
Okay, I assure you, he didn't have a gum in his mouth. Okay, so hopefully we've seen those. That gives you an idea of what we mean by these different terms. I'm now going to stop sharing and get back to my presentation. Okay, so this will help us move on quite quickly with the rest of the presentation because we've already gone through a number of these definitions. All right, so we will move on if I can. Excellent. So pathogenesis, how do seizures happen? We need three things. Okay, think of yourself on a Friday evening, you're pathologically excitable. So we need pathologically excitable neurons. It's Friday, something big is about to happen. And then all you need is something to spike that excitability. So throw in some alcohol, throw in a couple of drugs, and that acts as our glutamate. Now, what usually happens is when we throw in this alcohol of people pathologically excited on a Friday night, usually there are a couple of, fuddy-duddies. People like me who'll say, oh, no, we don't need that much alcohol. We need a bit. And those are the inhibitory projections. Now, a lot of times, if your inhibitory projections are not adequate or they're reduced, you manage to shut those people up, then we have a seizure. Okay, so you have pathologically excitable neurons, we have increased excitatory activity, and we have reduced inhibitory. It's important to remember excitation is glutamate, whereas inhibition is GABA, right? So there you have a few nicknames you can share with some of your classmates. Now, how do we classify epilepsy? We remember, epilepsy is not seizure. Okay, so when we're classifying epilepsy, this picture, and I really should put it back into slideshow, this picture depicts the fact that there will be still things going on the right. There'll be different comorbidities, diabetes, hypertension, or none. You could be a perfectly well person who presents with seizures and they become recurrent and unprovoked, and we call that epilepsy. So we classify epilepsy, one, based on the seizure types. And now we've talked about the different types of seizures. We've talked about focal, because we no longer call them partial. The reason we move away from that nomenclature is because when we say partial, it gives the indication that it's not a full seizure, but it is. So rather than calling it partial, we'll call it focal, meaning its origin. Okay, so we have focal, we have generalized, and there's some we just don't know. We admit that there are things that we are learning every day. And likewise, when we group these and they're unprovoked, we have different epilepsy types. And once again, they could be focal in origin, they could be generalized, both hemispheres, they could be combined, meaning at one point in time, your epilepsy was primarily a focal type of epilepsy. And other times it became generalized. Sometimes it goes back to focal. So we call that combined generalized and focal type of epilepsy, or it could be unknown. And then we'll talk about epilepsy syndromes in just a bit. Now, on the immediate right, yes, my other right, okay, you will find that the etiology could be various. It could be structural. It could be genetic. It could be infectious, so we get seizures after patients who've had a meningoencephalitis, because it has to be cortical, not just meninges. We get seizures in patients with tuberculous meningoencephalitis. We get seizures in patients with renal disease, liver disease, electrolyte disturbances, Hypoglycemia will give you seizures. And all these are etiologies that we look for in patients. We could have immune causes in patients with autoimmune encephalitis. Seizures is a very, very prominent finding. So it doesn't mean they have an epilepsy. It probably means that they have an immune-related seizure. So, and then we have unknowns. So as you can tell, we're quite comfortable saying there's a lot we don't know about seizures, even though we can say there's a lot we do know about seizures. Now, this is the classification of epilepsy from 2017. This is important because it more or less tries to group seizures into their onset, whether they're focal in onset on the left of the screen, whether they're generalized in onset, or whether we don't know. Now, as you will notice, even though we had said that focal onset seizures usually have intact awareness, you will see that under there, we categorize or dichotomize it into awareness and slightly impaired awareness. This is important because from the older classifications, we consider things like complex partial, because your awareness was not completely gone, a type of partial or focal epilepsy. And so now the nomenclature has changed a little bit. And so we have focal onset seizures with impaired awareness. And this would take us to things like motor onset automatisms, what we saw in the complex partials, okay? And these are the terms we've already talked about. We've talked about clonus. Atonic means complete loss of tone. So these are what we previously used to call salam attacks. So patients would be, especially in children, because they'd be seen in children, so the children will be in school, and they completely lose tone. And so their head falls and hits the desk. And that was the colloquial term for that was a salam attack, because how it resembles the prayerful thing, okay? So now we know, and now we have non-colloquial terms, we'll call them atonic seizures, complete loss of tone. You can imagine these can be catastrophically dangerous in children, crossing the road, complete loss of tone, fall to the ground, how dangerous that could be. Swimming, you get complete loss of tone, how dangerous that could be for a person. Next, we have things that we consider spasms. So this is especially in very, very young infants. We used to call them infantile spasms, but now we know that they can come a little bit later in life. But usually these will be neonates who go into a little sort of stiffening. And as you can imagine, when you look at a neonate, they have lots of odd movements. So it's a very difficult seizure to detect. And usually the mother will pick it out, because this is a mother who spends a lot of time with the infant and will be able to say, I've seen other babies squirm, but mine squirms a bit differently. And so that's what we previously used to call infantile spasms, but now called epileptic spasms. The generalized onset, I think, are self-explanatory. We can see there's tonic-clonic, there's clonic alone, there's tonic, there's myoclonus, which we've talked about. There's a combination of all three. Talked about the spasms. And then sometimes you have non-motor onset, meaning you just have the autonomic seizures. There are people who have what we call reflex laughing. So their seizure is really a laugh. And it's involuntary, it's unprovoked, and that is a type of epilepsy. Okay, so these are autonomic seizures. You can have cognitive seizures, you can have behavioral arrest, or some form of abnormal sensation, which technically is a seizure. So as you can tell, seizures can present in so many different ways. It's almost anything is possible. And as long as you can show that there was abnormal electrical activity, then it probably was a seizure. All right, now this is the older definition, as you can see, from 1981 at the bottom right there. It's a really useful definition, and that's why I still show it, because it simplified things. It groups things into partial, into generalized. We've talked about the different presentations of all of them, so they're self-explanatory. It grouped things into whether it was simple motor, or whether it was complex partial, like I showed you in the other, or whether it was partial, meaning it starts on one side and then secondarily generalizes. So this is a really useful classification to help understand. And things that have changed over time is in the next slide. We now no longer call them partial, we call them focal. And then the simple partial, we now call simple focal. The complex partial, we now call it still focal, but with altered awareness, like we saw in the video. And then the partial with secondary generalization, we now call focal with secondary generalization. Okay, so a few things about patients. How much time do I have? Yes, we will get through this. So if you have a 19-year-old female and a 65-year-old male, each presenting with a single generalized seizure, tonic-clonic, what sort of things would we be interested in? We'd be interested in the history, the causes, some of the triggers, what might be causing all these things. So in our history, We are interested in, was there a history of childhood seizures in the 19-year-old especially? We know this from children tend to go through seizures in childhood, which might disappear in early adolescence and then reappear. So a lot of times we need to ask about childhood seizures. And remember, the child might have no idea. The 19-year-old might have no idea about this. We ask the mother. The father might even have no idea. No offense to, all the males there. But a lot of times seizures, if they didn't happen very frequently, will just be a preserve of the mom knowing. So I always ask my young patients, call your mom. Or if their mom is there, I turn to the mom. Okay. Perinatal seizures, where there are seizures just after delivery. Of course, the patient won't know this. Nobody will know this except the mom. Was there trauma around the perinatal period? And then we look for triggers, things like sleep, alcohol, drugs, infection, because those can trigger a seizure. So I will recap the old classification. I'm really worried for time because you have another lecture at 12. Is that true?
Yes, we have another class.
So I will recap this at the end if I have time, okay? The 65-year-old, we look for different things. So in this patient, we're looking for cortical insult, things like stroke. So we're interested in whether you have hypertension, whether you have diabetes, all these risk factors. So we're interested in tumor in a 65-year-old, okay? So I'd be interested in things like headaches and figuring out how soon we can get a brain scan. And then I'm also interested in trauma. So once again, we look at triggers like sleep, like alcohol, like infection, and maybe even drugs, depending on what sort of life the 65-year-old lives. So next, we'll talk a little bit about epilepsy syndromes. Now, the reason I've put this slide is so that certain words start sounding familiar. I'm not going to talk about all of these, but I will mention about febrile convulsions. These are very important convulsions, tend to happen in children for anything from 6 months, tend to disappear at around the age of 6. They usually happen when the patient when the infant has a high fever. So once again, it's just the mom who knows. She'll know, oh yeah, every time my child used to get malaria, as they call fevers, it would always go very stiff. So these are the questions you ask. The thing about febrile convulsions as an epilepsy syndrome, they're quite harmless and they tend to disappear when the child is about 6 years of age, but they can come back in early adulthood as generalized tonic-clonic. It's important for us to ask about febrile seizures. Another important epilepsy syndrome would be the JME, or the childhood absence epilepsy. Now, it used to be called petit mal, as you've seen, and we've already shown what absence looks like in a patient. So when this happens periodically, that's a type of epilepsy. We'd call it the childhood absence epilepsy. The important reason for me mentioning this syndrome is because it can progress into other seizure types. So epilepsy and seizure, I'm going to answer Effie now. Seizure is the phenotype, okay? And it's not the phenotype, it's an electrical activity, whereas epilepsy has four things. It's a tendency to recurrence unprovoked seizures. Okay. Another important epilepsy syndrome to know about is the Lennox-Gastaut, which is at the bottom of your screen. The importance is it because it has several different seizure types. You're most welcome. Several different seizure types, and it's quite difficult to treat. So it's not a great epilepsy syndrome to have because of the prognosis. So this is a patient who might start with, febrile convulsions, or what we think are febrile convulsions, and then develop absences, all in a matter of years. And then as a child also has generalized tonic-clonic. So because of that, that sort of syndrome comes up. And this has a poor prognosis because the seizures are quite difficult to get under control. The last one I will mention is infantile spasms, like I've talked about it already. It's also called the West syndrome. Infantile spasms are quite difficult to treat, and they have a rather poor prognosis as well. So when we come up with these sort of seizures and we think it fits in line with that whole epilepsy syndrome, that's important as a prognostic factor. All right, now, the reason I've put this slide is for you to see that different age groups will have different causes, all right? And by causes, I mean the actual reason behind, not the trigger. So in a young neonate, and technically I don't deal with these anymore, in a young neonate, are absent seizures followed by loss of consciousness? No. Okay, so that's why they are so difficult to figure out. As you saw in that video, that girl snapped right back and she didn't have any loss of consciousness. She was unaware, but she was conscious. So prenatal injury is really important when you have seizures in a neonate. So we're going to take a very strong history. In patients who are 3 to 20 years old, we're looking at their genetics. We're looking about whether they had some prenatal injury. We're looking at infections. We're thinking about drugs, trauma, all the motorbike use, which comes with seizures after head injury. I see your question, Mohammed. I'll try and deal with it. And then older ages, we start thinking about brain pathology, tumors. Over the age of 60, we're now talking about vascular disease. Okay, so stroke, tumors. So you can see that the causes differ slightly by age, and that's why I put on that slide. Now, maybe I can deal with Mohammed's question. So automatisms are considered part of a seizure. So a patient who's having automatisms will usually have altered awareness. Tics do not alter your awareness. They're purely a motor. Okay, so automatisms are used in the context of altered awareness. I hope that answers your question. So how do we work this patient up? We start with the history and we look for, like we've said, preceding illness, fever, all these triggers, trauma. And then we get a really good response of what their seizure looked like. All right. So this is really important. In fact, this is the strongest part of your history in an epilepsy patient. You find out what the patient felt like, whether they were able to tell something was about to happen from the witnesses, what that actual seizure looked like. In the age of cameras and phones these days, I usually ask my relatives of the patient to try and video it. It's a very odd thing to do because your loved one is going through a very strange episode and you're worried. So it's very hard to just pick up your phone and start. But I really, really either need them to describe it or to try and take a video of the whole thing. And then we go into the post-ictal. So ictal is what's happening during the seizure. Post-ictal is what the patient behaves like afterwards. Usually the patient is very sleepy. A lot of times they have throbbing headache. For a long time, they might not be completely aware. So even though they're awake and they've stopped the jerking, they're not quite making sense. And that can last up to 30 minutes and some people hours. Sometimes afterwards, there's confusion, there's depression. They might look like a patient with a stroke, lose the ability to talk. They'll be very embarrassed because they don't know what's really happened. They might have lost control of their bladder. They might have bitten their tongue, so there's pain in their mouth. They're very embarrassed about this loss of control of the bladder. They have headaches. They tend to sleep quite a bit. They're quite exhausted. Some people go into psychosis, meaning they get completely disoriented and are psychotic. Some people go into a weakness like a stroke. So all these can be what we call post-ictal phenomena. Not everyone has them. You have to ask for them. So then we look into the past, their pre, their peri, and their postnatal history, whether they were febrile seizures, how their milestones were. Was there perinatal injury? Are there birthmarks that come in diseases with certain seizures, like tuberous sclerosis or a port wine stain? We look into whether this patient has other types of seizures. We ask about myoclonic jerks. We look into family history, things like stroke and head trauma, an infection in the brain. We check in women if it's related to their menses. We look for triggers for these seizures, and you ask the patient, have you noticed anything that brings it? Now, some of the common triggers include sleep deprivation. Sometimes around the menses, women get more seizures. Flashing lights, loud music. It's very Hollywood-esque. It's talked about, but it's actually very rare. So I don't spend too much time asking about loud music and flashing lights. Fever, very common trigger. So when you're acutely unwell, you've just picked up COVID, you end up with your first seizure. What just happened? Then we look back and find out that you actually did used to have febrile seizures. So we examine. The beauty about a seizure patient is examination is very, very structured and very quick. If you do two things, if you look for skin changes that suggest neurological disease, so what we call neuroectodermal signs. So you can look for features of neurofibromatosis, which would be a cafe au lait spot. Or you could look for features of tuberous sclerosis, which could be subungual fibromas at the nail beds or a nasal bridge rash, nail changes. This tells us that this patient is more likely to have seizures because of their neuroectodermal features. And seizures are very common in neurofibromatosis and tuberous sclerosis. So then we look for focal signs. Does this patient have a weakness? Does this patient have an aphasia? All right. Does this patient have pupillary difference in sizes and anisocoria? And then lastly, we must listen to the heart because we know that arrhythmias can frequently provoke seizures. Okay, so you can have cardiac provocative factors of seizures. So we must listen to the heart and figure out if that pulse is regular. That is really what we must do. So how would we investigate? For both these patients, our 19-year-old, our 65-year-old, we do some basic bloods. Blood sugar, sodium, magnesium, calcium, phosphate. These are basic because either too low, mostly too low, or too high can trigger seizures. The LFT is very important as well. A toxicology screen, as we've said, different drugs can provoke seizures, important. And then we must look for arrhythmias. So we also do an ECG, and we look to see if there's electrical abnormalities. So we do an EEG, an electroencephalogram. Right? The 65-year-old, like I said, because we're thinking about things like vascular disease, we'll start right ahead with a CT scan of the head. We'll go on to the metabolic profile as well, the blood sugar, magnesium, calcium, phosphate, kidneys, liver. We'll once again look at the ECG and EEG. Now, when we come to brain scanning, in epilepsy, an MRI is a better scan because it picks out a lot more. But we don't run to MRI every patient for the sake of cost. Okay, so really this would be a good way to start. And if an MRI is possible, then we move to the MRI. Some of these are the metabolic triggers, like we've talked about: low calcium, low sodium, low glucose, low magnesium, liver failure, renal failure, anoxia. All these are metabolic triggers of seizures, so we must look for them. And then there are many drugs that can also trigger seizures: cocaine, amphetamines, toxic levels of penicillin, all right, aminophylline, and also withdrawal from things like alcohol. So we ask all these questions when we're taking a history, and now we know why we're asking these questions. So we worked up this patient, we've done the labs, we've done the tox screen, we've done the EEG, and then we image. So depending on whether we thought that this patient had infection or fever, we might even throw in an CT scan of the brain or a chest X-ray. MRI, like I've said, is preferable, but it's not urgent. So there's no urgent MRI for the brain and seizures. No, we start with these others and then we do the MRI. An LP is not indicated in all seizure patients. So I'm going to say when indicated. If your patient is positive and we're interested in things like meningitis or encephalitis from the history, then we might be justified. Likewise, a prolactin level is not indicated in every patient. We do it sometimes if we're not sure if this abnormal behavior is a seizure or not, because prolactin levels tend to rise 10 to 20 minutes after an event. So you can imagine it's a useless test to do 1 hour later. But if this patient has just had a very odd episode in your clinic and you're not really sure, then you can do a prolactin level. So would we start a drug on these patients? Which one and why? Good question. Now, when we're starting management of drugs in these patients, we consider the cause of the seizure. We consider whether it's a single seizure or not, because we don't start drugs on single seizures unless there's a high risk of recurrence. And we consider the side effects. So there are certain drugs I'm not going to use in women of childbearing age. There are certain drugs I can't use in children. There are certain drugs that work better in children than they do in adults. So these are all the considerations. Now, you're going through pharmacology. I know you know these specific first-generation anti-epileptic or anti-seizure medications. Is what we call the second generation. And sometimes we might even send the patient for epilepsy surgery outside the country. There are different pros and cons to each of these drugs. We'll get to that as you get to 6th year. The important part, don't start an anti-epileptic drug or an anti-seizure medication on a patient with a single seizure. We work up for the likelihood of recurrence. The 65-year-old gets a CT scan, Niharika, because in 65-year-olds presenting for the first time with seizure, we need to think about vascular problems. So we need to look for a stroke. All right. So that's why a CT scan would come way up front. In a 20-year-old with a seizure, I'm not thinking about stroke. I'm thinking, did you not sleep well? Have you had seizures as a child? This is just coming back. So that's why we go straight to the CT scan, the 65-year-old, much earlier than we would for a 20-year-old. I hope that answers the question. Okay, no problem. What do I mean by a single seizure? Exactly that. Okay, the patient has had a single seizure. They were at home. Their loved one saw it and brought them to hospital. I mean exactly that. A single seizure. It's happened, never seen before, never happened before. That's what I mean by a single seizure. Okay, perfect. We are almost there. So your choice of anti-epileptic drug, like I've said, depends on the seizure type, on the cost. And this is really, really, really important. Okay, the cost, because I'm not going to prescribe an expensive drug for somebody who is unlikely. Anti-epileptic drug is what AED is. So these are the drugs that you're learning about in pharmacology. I'm not going to prescribe the most expensive drug for somebody who is not going to afford it, because we know that these drugs are taken long term. They're not taken for a month, they're not taken for a day, they're not taken for weeks, they're taken for years. So there's no use putting you on a drug that's going to really put you into poverty. So we consider cost. We consider whether you're female. There's certain drugs we don't use in women of childbearing age. We consider whether there are IV formulations for these drugs in case the patient has what we call status epilepticus. What's the difference between seizure and convulsions? These are terms that we use interchangeably. Convulsion, seizure, fit, all these are used interchangeably. Okay, so there's no real difference. Lifestyle advice. Okay, so when you've met a patient with seizures, we tell them that sleep is part of their treatment. So they must aim for 7 to 8 hours of sleep every night. They need to avoid alcohol because alcohol is a potent trigger of seizures and it's not dose dependent. So some people might get away with 1 glass of wine, other people might not. Some people might get away with 5 beers, other people might not. So it's not dose dependent. So we say try and stop it. Okay, and then avoid dangerous activities like swimming alone. We're not saying don't swim. We're saying try not to go swimming alone. Go swimming with somebody with life-saving capabilities. So don't go swimming with me. I can't save your life. I can barely swim myself. Because if there's a problem, you need to have somebody there who will be able to help. Cooking alone, we're saying don't cook. We're not saying don't cook. Those are too negative. We're saying cook, but cook in a safe way. All right. So try to avoid doing all these wonderful cooking things. I'll answer your question, Nelly, just a bit. Try to avoid cooking all alone in your house with the door locked. If you have a seizure next to an open flame, how dangerous can that be? Okay, so we need to just think through things. And these are things that are on the internet, thank God. Driving, once again, when you've had a generalized tonic-clonic seizure, we really should avoid driving. For different countries have different legal requirements. But I'll tell you, in Kenya, I don't know if it's luckily or unluckily, we don't have specific legal requirement for this, but in the UK, your driving license